are ocular migraines associated with stroke? And I was being smarmy with my answer. I'll elaborate a little bit more. There's an association when people talk about ocular migraines. What is that? So ocular means eye, and the migraines are a kind of headache. And in fact, migraines aren't headaches. You can actually have a migraine and have no headache whatsoever. And so that's kind of what she's getting at, is that people have these visual symptoms, blurry vision, spots, twinkles, whatever, and then don't have a headache with or without headache. And is that associated with a stroke? There's literature showing that those people who have those symptoms do have a higher risk of stroke. They do MRIs or they follow them up longitudinally and they end up with strokes in their brain. And why is that? Is it because the migraine causes the stroke, or do they have symptoms that look like migraine? They're actually a pre-stroke symptom. And from my experience, people who have visual symptoms and headaches or without headaches but end up with a stroke often had the syndrome beforehand. It wasn't the migraine that caused a stroke. It's just that was part of the symptom of the syndrome they had. So it's a little complex. But what I'm talking about is there's other diseases. So my analogy is when you hit yourself in the head, I don't do this on a regular basis, with a hammer, with a brick, with a rock, with a chair, you get a headache. But the causes were caused by multiple different things. So just because you have a headache doesn't mean it's a headache. It could be something else. And I think I handed out one thing about headaches because it's very important. It's not just because I'm trying to sell my services on headache. It's this headache is very important in the evaluation of stroke, because I have several people who come in for evaluation of headache and they turn out to have aneurysm, a dissection of their artery, autoimmune disease, something of that nature that actually could lead to a stroke if we don't take care of it. And the only manifestation they had was a headache or a single neurological event, numbness, tingling, vision changes. So long answer for good question.
So you've definitely, hello? You've definitely sold me that I need to take care of myself in terms of knowing what I'm doing, and that I need to choose the best hospital to go to and the best people to see there. But I don't know how to make that choice. So after I call 911 and a random ambulance comes, I say, take me to Aaron. I want to go down to Retton. I mean, I live in Woodinville. I don't think they do it.
So you bring up a good point, and I set myself up for that question in the first place. I was hoping we could answer that question during the tape transfer. Is that, yeah, I mean, I do hand out my cards to people, absolutely. I mean, I have politicians, I have all these CEOs, I have other people that I take care of, and actually my card is in their wallet, and they actually will call me, and they have called me for family members for events, because they know that they can call me. But that's not practical. I can't be around 365 days, 24 hours a day. I have to sleep at some point. So you're correct. So what do you do? I don't have an answer. I've been working on this actually for the 8 years I've been back in Washington. I was actually born at Overlake Hospital. Just to give an idea. Went to Bellevue High School. This is my town. This is my home, and I came back here to do just what you're describing. How do I just call up randomly and get the exact same care if I called up here in Spokane, Okanagan, whole rainforest? When I show up to a center, am I going to get the same care no matter where I show up? And I've been working diligently trying to figure out a way to get everybody to work together in terms of making everything the same. And I was very naive, I got to tell you that, because that's not the case. And you know that's not the case. When you're talking about medicine, which is still a business, not that I'm socialized medicine, gotta watch out for what I say. Balance, it's all about balance. Be careful. Is that I'm trying to get everybody to take care of it, but the problem is that everybody has their nest, and they want to make sure their nest is the best. They want to make sure all the patients go to the one little nest, despite whether they can take care of the patient with that problem or not. And so the answer to the question is, I don't know. I don't know how to get you to the same level of care no matter where you show up or who you call at this very moment. But I'm working on it. I really am. And that's where this little telemedicine allows us to do that, allows us to level the playing field. Because a lot of hospitals kind of take a market and say, we're the best, whether they're the best or not. They just say, we're the best, come see us. Well, guess what? Now there's choices. And I can go into a market and say, you know what? You're not necessarily the best in this. We can actually equal the playing field so that people can get a higher level of care so there's not a monopoly in this situation. And that's what I'm trying to do here in this area. So it's not easy. Did I scare anybody out there? No one wants to call 911 anymore.
How can one determine the difference between benign positional vertigo and something more serious?
Yeah, that's a very good question. A lot of people, I mean, when I was training in Boston, I mean, I feel like I got a pretty good training in Boston. They cogitate a lot, they sit a lot, they think a lot. I'm going to get in trouble by my mentors, but they talk about this a lot. Can you differentiate between benign positional vertigo, which is basically you have an inner ear function problem where these little seaweed with rocks on the end move around so you know where your head is in space, and one of those rocks breaks loose and goes slamming into the seaweed, making you feel kind of dizzy, versus the possibility of, like we had up here, a person who presented with dizziness who died the next day. How do you differentiate that? Sometimes you can't. Sometimes we don't have enough information, including with regards to examination. It's very helpful to have an examination, someone who specializes in this. I do this all the time. But sometimes we need a little more information. Sometimes we need to look inside. We need to actually look at the arteries, look at the brain, look at other causes of things that would cause people to be dizzy. So that way, benign positional vertigo, which is actually what's called the diagnosis of exclusion, meaning we have excluded everything else and we think it's this. Versus sometimes we actually just jump to that conclusion going, oh, it's obviously benign positional vertigo. Here's some meclizine anti-dizzy medications, go home. Well, guess what? Statistically, the doctor's going to be correct if they don't look, right? So odds are you have benign positional vertigo, you're going to be just fine. It will go away. Do you want to be that statistic? Or do you want someone to evaluate you? And that's a very good question, and that's called allocation of resources, and we're debating that right this very second. Do we treat everybody statistically? Well, statistically, if we did nothing for any of you, ever, statistically, you should be okay. You should live to an average age and die of an average age. But some of those people should live 10, 15, 20 years longer with a good quality of life if we actually would have looked or prevented medicine. So right now we're talking about allocation of resources to diagnose a disease that statistically is benign. And so we need to look. And that's the debate we're having right now is, are we going to be able to look and diagnose people who actually don't have a benign condition and actually is more malignant? Right now you're allowed to look when you have these kind of symptoms, but soon we may not be able to look. So actually that question you had is a good question, and actually it goes into a higher level of resources of care.
My question's actually kind of related to the last two, and that is, I had Bell's palsy when I was 19, and they treated me as if I had stroke. I don't think they gave me a blood clot treatment, but my grandfather as well was also treated as if he had stroke, and he had brain cancer. My question is stroke the most time-sensitive issue that you can be dealing with when you're dealing with that set of symptoms and circumstances? Is there anything else that is more pertinent that should be dealt with first, or is it best to treat someone who is showing those symptoms as if they have a stroke and then move on to other possibilities?
Yeah, it's a good question, and I think the point I would like to make is that when a person comes in with a focal neurological symptom or any symptom whatsoever, you want to make sure you rule out the most dangerous thing that would cause that symptom. And if stroke happened to be on that top of the list, or bleed, or aneurysm, or whatever it is, you want to rule that out first. And then you go to the second level. Absolutely. So just to clarify your question, you had Bell's palsy, and they treated you as if you had a stroke.
I think they tried to eliminate that initially, but yeah, they put me through all the stroke tests first.
Right. Which is appropriate. I mean, like you said, they can't differentiate. They're having a tough time differentiating between what's a stroke and what's not, a benign entity. I don't know if anybody knows what Bell's palsy is. That's where your face kind of goes weak, and it's because your nerve gets infected by a virus or autoimmune disease sometimes, and you can't move your face. They want to make sure it's not something going on inside your head like a stroke. And oftentimes in the early stages, you can be fooled because some people just have a facial droop like this, and that's part of the fast, right? That's a stroke. But then a couple hours later, they can't close their eye, they can't raise their eyebrow, and then it becomes more clear that it's not likely a stroke. But in fact, I've had 2 cases in my life where actually the Bell's palsy was actually a stroke, including a 21-year-old woman. So you kind of want to rule this out, absolutely. Most dangerous condition.
So I'm curious about the latest and greatest rehab activities and things that you're doing to help rehabilitate someone who didn't get to the emergency room right away?
Right, so that's a very good question. We had a little preliminary discussion before we started this. And with regards to therapy, you're an occupational therapist, and you're doing the right things. Apparently, she has a friend who's had a stroke, and we're trying to rehab this. What's the latest and greatest? How do we get people better from their stroke? Well, practice, we know that, but what are tricks? And she was talking about what's called constraint therapy, and that's where you basically have a left side of your brain and a right side of the brain. You think it works together, but if you put something down the middle, chop it in half, your one arm will do over here and your right arm will do over here. And it's because they operate actually somewhat independently. And so what you can do is actually take the good side that's functioning properly, tie it to the body, stop making it work, and make you use the other side. And so all of a sudden your brain starts rewiring itself to use the bad side. Another thing is mirror therapy. I don't know if I can do it with a microphone, but everybody knows the trick. You kind of do the twisting around and say move one finger. You have difficulties moving that finger when you point to the one finger. So basically what that is that you're tricking the brain to use the side that it thinks it's using. So it's called mirror therapy. You actually have a person look in the mirror and say, move that. And they think it's the same side that they're good at, but it's actually the bad side. And it tricks the brain in actually rewiring it. Pretty cool. Another thing is actually being worked on, which actually been worked on for several years, but we're having trouble getting it to market, is something called transcranial magnetic stimulation. And we had a little discussion on that. And that's actually taking a magnetic field and actually pulsing it. And you can pulse it to a frequency to either excite the neurons in the brain or to inhibit the neurons in the brain. Now, why is that important? So if you have a stroke and you can't move this one side and you want to move it, you can actually pulse this electrical field to make it work. So if you have some neurons left moving this arm, you can actually enhance that pathway. So the more you use something, the more your brain wants to use that pathway. It rewires itself all the time. Kind of an analogy is like depression. When a person gets depressed, they get easily depressed, and all of a sudden they fall into a funk, and they're more depressed, and they're more depressed, and finally they can't get out of it. Why can't they get out of it? Because their brain is rewired for depression. You have to break it out of that. Drugs, therapy, you have to rewire that brain to actually think in a different manner altogether. It's exactly the same way as using this therapy. You're using the pathways that are already built and enhancing them. So when you have a stroke, you've lost a ton of pathways. Now you need to regrow them. So you use this electrical impulse to actually excite it. The other one is to go to the other side and inhibit the good side, just like you did with constraint therapy, and actually work it. And so that's another thing that's really cool. They actually had a bunch of studies where they actually took the person's scalp off and put the electrodes on. That's a little invasive. And I have a problem with that because there was a lot of things available to actually do the external studies without actually opening the skull. And here's another one of my conspiracy theories, all this kind of stuff. Can you imagine why they would take the skull off and put the electrodes on the brain instead of just using the external? Make more money? More money in devices, right? So a lot of this stuff that we're seeing come out is actually a lot about investment, and so it's not necessarily about good patient care. So this external stuff I think is really exciting, and they're actually starting to do studies right now. They just announced at the International Stroke Study Conference that they're doing it on kids. So you have to, when you do studies on adults, you have to jump through this many hoops. When you do studies on kids, you have to jump through this many hoops. You can imagine if they're doing it on kids, okay, you could probably do it on adults. So I think more and more we're going to see these kind of therapies come out.
Yeah, my question is that as far as symptoms to stroke, where do you list head trauma?
Head trauma as a symptom of?
Symptoms to stroke.
You mean like head trauma causing stroke?
Yes.
Or, yeah, head trauma can lead to stroke, and I'm just forming the rationale for my answer in my head right now, is that when you smack your head, you can bleed, right? That's obvious. You break the blood vessels, either veins or arteries, and you have a stroke. The other answer to the question is you can actually, head trauma in terms of whiplash, right? Everybody knows about whiplash. You know, you get in a car accident, you whip your head back. Well, these little arteries in the back of your head run in a little bony canal. And those bones are sharp. So you can imagine you're whipping your head around. Those arteries can actually be torn. It's called a vertebral artery dissection. And so people can actually have strokes after a motor vehicle accident without hitting their head. And so a lot of people talk about, you know, chiropractors causing stroke. Well, in fact, I'm involved right now with a study trying to demonstrate whether chiropractors truly cause stroke, or is it because most people who get in motor vehicle accidents show up to the chiropractic's office and the chiropractor is left with a person who already has a dissection and they're just making the situation worse because they don't know what's going on. So in fact, we're doing a study to show that people after motor vehicle accident, we're doing some testing on the vertebral arteries to see if they have a susceptibility to manipulation before the chiropractor actually does the manipulation. So that is a way of having a stroke, a mechanism of injury with a whiplash injury. So I'm not sure I got to the meat of your question with regards to. Okay, good. All right.
Question on the diagnostic tools. You mentioned CT and you also mentioned ultrasound. Is ultrasound good enough? The reason I'm asking is there's coming out with, as far as leveling the playing field, ultrasound is becoming very cheap as opposed to a CT. Is it sufficient to be used as a first diagnostic tool?
Yeah, and here's the answer to the question, is that each modality we use gives us a different piece of the information. The problem is when we're trying to get this piece of information, insurance companies don't know the difference between them, right? So we try to get an MRI, which gives us a different piece of information than a CTA, then a CT, then an ultrasound. So each individual test gives us a different piece of the puzzle. What does the brain look like? Is it an acute stroke? What's in the artery? What does the artery wall look like? What's the flow within the arteries? Is there collateralization, meaning do the pipes, because basically stroke is just a bunch of pipes. I'm a plumber, right? So do the pipes flow around the clot? So ultrasound is very good at finding one piece of the puzzle, but it's not the whole piece. And in fact, what I didn't present up here is the cool stuff that we're doing with regards to clot busting. Actually, when you give the people the clot busting medication, you actually put the ultrasound probe on the head to do ultrasound. Like the little sound, just like when you do ultrasound in the belly, do ultrasound in the head, different frequency though, actually vibrates the clot and helps bust it up. And so it's a different piece, a different tool we can use. And it's not the only tool. We need that other information. We need to do the CT. We need to do the CTA. Sometimes we don't need to do the MRI. So sometimes you do everything and you're going to get busted for it because you really don't need to do anything. But sometimes you do. And so if we're overutilizing some of these services, we got to be very careful because pretty soon they're going to put a clamp down, and when you do need that service, it won't be covered or available. But with regards to the answer to your question for ultrasound, it's necessary, but it's not sufficient. Right? You need a little bit more information to do that.
Yeah, because the reason I was asking is, they're actually putting ultrasounds on iPhones now, so they're becoming pretty ubiquitous out there as far as a diagnostic tool.
Absolutely. One of the people I know in Germany actually came over just a few years ago and actually had something the size of an iPhone, which was powerful enough to actually do what's called a transcranial Doppler, look inside the brain, which is pretty impressive. So, yeah. Absolutely.
You talked about the shrinkage of the brain. At what age does that start? And is there any way to minimize that?
Yeah, I heard too late. Yeah, it was out there. Once the brain starts to shrink, we don't know if we can stop it, slow it down. Definitely can't reverse it. What starts it in the first place? Definitely stop whatever you're doing that's causing the brain shrinkage. And then what age does it actually start to occur? It can occur at any age. Any age that is causing your brain to be malnourished, lack of oxygen from smoking, from carbon monoxide poisoning, lack of vitamins, whatever it is, your brain will start to shrink. And why does it shrink? It's because the mass is no longer there. The neurons are still there, right? They may die, they may not function properly, but they're still there. So are the little axons, the little connections. They just shrink because they're no longer either being used properly or they're being damaged. And so whatever causes it, you can have shrinkage at any age. Now, technically, your brain is actually wiring itself up to between 18 and 22. You actually have what's called myelin. And it's like there's a little connection where everything kind of forms. Myelin is a sheath, like the little plastic around your cord that helps your neurons run faster. So I'm going to give excuses for why kids act the way they do, but you actually don't myelinate your brain fully until the age of 20, 21, 22 years of age. So in fact, your impulse control really isn't there until you're that age. And so now it makes sense why when you're growing up, why did I do that? That was kind of stupid. So that's why, because your brain wasn't myelinated. So I just gave my daughters perfect opportunity to use an excuse, right? Dad, my brain's not myelinated yet. So Yeah, so basically, probably after that age, you actually start to accumulate damage.
It doesn't naturally shrink then.
It does, well, that's a good question. I don't think there's actually been a definite study saying does it just naturally shrink, but by theoretically, absolutely. I mean, you just think your brain loses its neurons over time, it shrinks. But how fast is it going to shrink? That's the key. You looking for an excuse? Is that what the...
Hi. This question is about not exactly stroke, but it's related to it. So I know a person who was diagnosed with
Transient global amnesia.
transient global amnesia, and the way they got there was by eliminating all the fast symptoms, I think. And so it's really a two-part question. Is it possible to actually be diagnosed with transient global amnesia but not show fast symptoms and actually have a stroke? And what exactly is transient global amnesia?
No one really knows. That's the answer. So, but I can give you all the theories. How's that? Is that fun? I can pretend. So, transient global amnesia, transient meaning brief. Well, it can last up to 24 hours. It's not so brief. Global means it's involving all your brain, but in fact, it's not involving all your brain. It's involving just your memory. And then amnesia gives you the definition of what the symptoms are. You can't remember anything. It's like you walk into the room and say, "Hey, how you doing? My name's Dr. Heidi. How you doing?" "Hey, do you know my name?" "Well, what's your name?" "I'm Dr. Heidi. I'll be right back in a second." "Hi, how you doing? What's my name?" "Did I see you before?" So that's what it is. And it's really annoying. I mean, if you're the spouse or the relative of this person, they're like, "Okay, this guy's going crazy." And that's actually what people think for sometimes they bring them in because, oh, they're just trying to get out of chores. I got that one. You know, he was out in the barn, he wasn't washing the windows, and he just comes in saying, "I don't know what I'm doing," and he thought that he was, just faking it. So what it is that you lose the ability to remember things. You remember everything before the event, but not after the event. So your memory in your brain is actually separated within your brain. There's the hippocampus, which is the medial part of your brain, actually takes in information, processes it, and takes in that immediate memory. But then as it comes in, it deposits in other part of the brain, which you'll remember permanently or temporarily for some of us still. But what happens is it goes away for 24 hours. It's like you took the reboot on the computer. You just turned it off and just asked the same questions over and over and over again. They know their name. They know, but they can't acquire new information for 24 hours. So the question is that a stroke? We don't know. There are arteries that go to that brain. There are venous structures, the drainage of the brain to that part of the brain. So do those get clotted? That's part of the theory. It could be a stroke. Could it be a seizure? That's where most of your seizures occur, is in that part of the brain. So it's very possible this is actually a seizure. So there's a lot of theories here that we just don't know how it works. All we know is that after 24 hours, the person's absolutely normal again. You do an MRI, there's no stroke. You do a CT angiogram or MRI, or MRA, which is the angiogram of MRI, there's no stroke, there's no clot, there's no nothing. You do an EEG, there's no seizure. So what the heck is it? We still don't know. Could be a deep brain seizure, could be a small TIA of the hippocampus, absolutely. Does that portend to another problem? We don't know. And I actually watch those people very carefully because we don't know. I want to make sure, like we were talking over here, you don't exclude the most dangerous things that this could be.
Based on your experience, do you think that the cell phones have any damage or any effect on our brain?
Oh boy, hyperbole and hypotheses, that's what I'm good at. I love speculation. Let's just say I don't put this to my ear. We don't know, right? So the question is, when we look at the incidence of any disease, is the disease more prevalent and have more incidence because we're looking for it more often, or is it because it's actually there more often? And so when we're talking about more brain tumors that we're diagnosing, more cancer we're diagnosing, is that because of what we're exposing ourselves in the atmosphere, or is it because our surveillance programs are so much better? I don't have an answer to that, but I don't take a chance. We don't know. You're talking about high frequency waves, and you're talking about anything you're using near your body that can alter it and absorb that information. I don't know. I don't know if anyone really truly knows. But why take a chance? If you can do some simple prevention, why not, right? If it could hurt you, why do it unless you really enjoy doing it? We'll talk about those little habits later. But in terms of something you can simply do to avoid a situation that could harm you, I don't know. I really don't know the answer.
We have time for a couple more questions. I'm going to come here and then there.
So, I was questioning about what are some of the steps to make healthy blood vessels that keep down the inflammation? I mean, obviously the smoking and the drinking diabetes under control, but what are some of the other steps we can take?
Right. A strong thing that my wife actually did some research on in Boston is something called anti-inflammatory diet. And what that is that for some reason, if we eat fatty acids in certain ratios, it's not just eating fish, it's not just avoiding beef, it's actually the combination of these fatty acids somehow influence the enzymes that make inflammatory markers that damage or heal tissue. And if you eat them in the right ratio, the damage goes down and the healing goes up. So it's pretty cool. What else can you do? Well, there's something kind of on the forefront which actually is tied to that, which is the next step, and it's something called nutrigenomics. And I think it's very important to understand that how we expose ourselves to the atmosphere influences the way our body reacts, right? They do a lot of twin studies, right? Twin studies, one twin will get it, another twin doesn't. Why is that? There's something to do with the way our body is exposed to certain things, reacts, makes proteins, responds to our DNA response, our cellular structure response. So we don't know what more the next steps we can actually take to actually influence our body to heal better. So the obvious is stuff that we know. This other stuff is pretty fancy and pretty cool, but I don't think we're going to know for quite a while. And so, but this anti-inflammatory diet is about as cutting edge, I think, as we can get, including what's called antigen-free diet. That's kind of the next step as well. And that's what's more basic than what we put in our body, right? I mean, that's what makes us. So if you put something in your body, how does it build? How is it metabolized? Well, sometimes things we put in our body doesn't react well, right? We have stuff that actually our cells respond to, like bacteria or viruses have little proteins on them. That's how we fight them with our immune system. Same thing happens. Every piece of food has a cellular structure that has a protein on it. So you put that thing into your body may recognize it as foreign. So why do you feel crappy when you have the flu? Is it because of the virus? No. It's because your own immune system makes you feel crappy, because the only way you're going to heal from the virus is to feel crappy, go sit down and sleep. The body knows that. Same thing happens. So if you eat something that your body doesn't like, it causes inflammation, right? Everybody's hearing now more about gluten sensitivity, right? You don't have to have sprue. You don't have to have the antibodies in your blood to have this. I have it. I found it out 3 years ago. I was having problems. I could barely walk. I was feeling awful, crappy all the time. My wife's a dietitian, finally tricked me and put me on a gluten-free diet, which really tasted awful, but it's better nowadays, okay, so don't think it's scary. And after just 4 weeks of being on this, I was able to run 5 miles without sweating. I felt great. I was getting up in the morning, sleeping properly. I ate wheat all my life. So you can develop this later on in life where your body just doesn't like the food that you're getting because of this little sensitivity. So wheat, whey, casein, I mean, we hear about this. So just because you were able to get away with it a long time ago doesn't mean you can get away with it now. So always reassess your body. Listen to your body. If you're having abdominal pain, you're feeling tired, you're not able to do things, reassess what you're doing. You may be doing it to yourself, right? Drinking caffeine, you're not sleeping, you're doing the bad things. We talked about that over here. But in terms of reassess, if you're not feeling well, you're not feeling well for a reason. And it may not just be age. It may be that. You may have developed something over time that you were able to get away with before, but not able to get away with now. And so that's a long answer to the question, but I think good points to make.
I believe we have time for one more question.
What's the current understanding of Alzheimer's disease as it involves the issues that you've discussed today or described today?
Right. So we're talking about Alzheimer's disease, which is associated with dementia. It's named after a person with regards to developing memory loss and cognitive issues over time, Alzheimer's disease. Well, that term was overused. Now we're starting to differentiate and find out that all Alzheimer's diseases are caused by other sorts of processes, which includes lack of blood flow to the brain. And so we're finding out that when you don't have blood flow to the brain, your brain shrinks. In certain regions, you get memory loss, you get cognitive loss, and it can be mistaken as Alzheimer's when it's in fact now termed multi-infarct dementia, but it could be ischemic dementia. You don't have to always have strokes to have dysfunction. And so we're finding out that there's actually genetic susceptibilities where people have blood vessel abnormalities. You inherit a problem with your blood vessels or your brain, or you have something, a fancy disease, which is called amyloid angiopathy. And what that is your brain's confused. It wants to develop Alzheimer's, but instead it deposits the brain in the blood vessels and causes you to have strokes and bleeds. Oops. So instead of just losing memory, you actually have strokes and bleeds and usually die from that process. Same protein, different process. So there's a lot of genetics that goes on with regards to developing of our whole body, especially the brain. So with regards to Alzheimer's, sometimes it's misdiagnosed. Sometimes it's actually due to a different process. And sometimes you have to look. And the only way to find is to look. Yeah, and that's the question is that what can we do to kind of slow down the process of our degenerating brain? Inevitably, our brains are going to degenerate no matter how long you live. It's inevitable. Can you slow it down? Can you slow the process? Well, like I said, genetics has a large part to it. So if your brain is preliminarily degenerating because of your genetics, what can you do? Not a whole lot yet. We don't have all the understanding. We're trying to figure out ways of removing the abnormal protein or getting more blood or slowing down some proteins that are being produced. We don't have all the answers yet. A lot of the studies that we were trying to figure out Alzheimer's and slow it down with all these fancy new studies have all failed recently. So we just have all these old drugs we've been using for 10, 15, 20 years. We have nothing new.